Just briefly, it is a very well-known paper, I think, and okay. So we all know the unmet need of neuroblastoma in the context of relapsed refractory or a risk. This is the disappointing historical course, now something changing, but not enough maybe. So one possible solution is to use the CAR-T therapy in the context of an anti-GD2 therapy. And this is the pioneering work of 2011, so many years ago, of a first-generation CAR-T, and in which T cells doesn't persist so much, but in some ways they were able to give some remission and some response. So it was the first hope for this therapy in the context of neuroblastoma, and many years have passed and many things have done until we have come with this product that is a third-generation CAR-T product that is composed by two co-stimulatory molecules that means that they can persist so much longer than the first-generation products, and in this case we have safety switch by which we can stop the CAR-T activity in case of excessive toxicity as an additional safety measure. So this product was developed at the Ospedale Pediatrico Bambin Gesù. This is an autologous product, the one that is presented in this work, and it has a quite good production time and is administered as any other CAR-T therapy with a previous lymphodepletion. So the authors try to investigate the safety and efficacy of this product in the context of relapsed refractory or high-risk neuroblastoma, and they perform a phase 1-2 trial. In the phase 1 part, they only enrolled patients with refractory or relapsed disease, and in the phase 2, they open also to patients with high-risk disease intended with these characteristics. And they designed the trial as a dose-escalating one with the starting dose and a 3+3 design. And in case of dose-limiting toxicity, they come back to lower doses. But I can spoil you that everything was okay. So they upscale until the final dose, DL5 of 10 per 10 CAR-T per kilos. So this was the characteristic of the population. 27 patients were enrolled. That is a quite huge number considering the disease. And all the patients were with 3 or more previous line of therapy. So it's a heavily pretreated population. And at the disease status of the enrollment, they are made relapsed or refractory with balanced cohort. And there was, for the phase 2 trial, one high-risk patient that was given CAR-Ts for the consolidation purpose, that was without evidence of disease of the first line. And interesting, 13 patients did already receive dinutuximab therapy in this trial. So the question is quite interesting if it works or not. To be complete, half of the patients were MCN mutated. So how many infusions they gave to patient? Usually we are we used to acute leukemias in which one infusion is our target, but in this context of solid tumors, to overcome the limitation of these therapies, multiple infusion could be indicated, and this is the case. It's difficult to see because there are little stars beyond the colors, but in many patients 2 or more infusions were given. And these are the mainly reason for doing many infusions. So did the CAR-T worked in lab terms, let me say. So if you notice the expansion of the cells, both by flow and by digital PCR, the expansion was quite good and robust, especially in the case of the maximum dose that were given. And also the persistence of the cell was quite satisfying, because they were detected until 30 months after the infusion of the products. About the toxicity, these are the general pattern of toxicity. Most of them are related to the CAR-T therapy. Other are on-target side effects that we could reconsider. The cytokine release syndrome, almost all the patients had some grade of CRS, but almost low grade and easy manageable in an expertise end. They didn't see central neurotoxicity effects, surprisingly. They didn't expect that, so quite interesting. And neither peripheral neurotoxin effects that could be expected in the context of anti-GD2 therapies. And the second most common effect was absolutely the hematological side effect with anemia, neutropenia, thrombocytopenia. So they have the chance to activate the safety switch in a patient with CRS onset. And as you can clearly see here, after the Remidoside, the administration, the CAR-T expansion goes at low levels and persists for a long time. But after that, you can see that the expansion starts to grow again afterwards. So the Remidoside activity can lower the CRS rate, but is not able, in this term, to kill all the CAR-T products. So it's a very interesting point because it can persist the anti-tumor activity over time. And another question was if this expanded cell was still sensitive to Remidoside, that could be a safety issue, and the answer is yes, they are still sensitive to Remidoside, as you can see in this in vitro assay. How about the outcomes? If you remember the curve, the Kaplan-Meier of the start of the presentation, these are pretty different because 3-year overall survival of the whole cohort was quite satisfying, but if you look at the recommended dose, it's even better. And in patients who achieve the complete remission after the CAR-T cell therapy, the overall survival and the progression-free survival is very high, considering the patient population. Interesting, the study is not developed to detect differences among groups, but patients with low burden disease go really, really better when compared to other ones. So this is another point of speculation. And another important point is about the previous GD2 treatment that they received, but the previous GD2 treatments didn't affect the efficacy of the CAR-T products. Another interesting point is why patients are resistant, why some patients are resistant. So is it a matter of loss of the antigen, so antigen escape? No, because the antigen was still expressed, as clearly stated. Was it a matter of expansion? No, because expansion was clearly sustained also in non-responders, so that's not the problem. Another thing, the exhaustion, does the CAR-T cells exhibit an exhaustion phenotype? Neither. So it's not these are the not relevant mechanisms. So in a previous study, they demonstrate that this polymorph meloderived suppressor is a strange population of cells that could alter the activity of in vivo cellular products, and they demonstrate that they could lower the efficacy and of the CAR-T products, and especially in patients who were, in this case, this is another study, or a previous study of the same group. In patients who were not responder, they have an inverted ratio between these myeloid precursor and a CAR-T. So this is a point that needs to be investigated, but it's quite interesting. So the limitation of the study is quite obvious that there is no power for the risk stratification that will be addressed in a subsequent study. There's no long-term effects because the follow-up is so narrow. And we have just one patient that received the CAR-T as a consolidation therapy before first complete remission. But I think there's a hope because the expanded cohort, the use of allogenic products that have a different pattern of feasibility, and the timing of the CAR-T, so try to put the CAR-T early in the treatment, are endpoints that were already being addressed in subsequent studies and are partially presented, were partially presented at BMT this year. So the next step will be probably a multi-center trial and the preclinical target of this myeloid suppressor. So for concluding, we have very encouraging results, both in terms of efficacy and toxicity, but the point that made me to choose this article is this simple phrase that was made from a parent a few days ago. She comes back with his child to our center from OPVG, where he had this type of treatment, and he said it was very easy to stay away from home for such a long period of time. So we are growing in expertise, and we are proposing new therapies, but maybe we have to think about something parallel. So we have to think about how to convey those therapies as closer as possible to patients, and to avoid travels and long periods away from home and from the So thanks. And that's all.
Thank you for the last point. Comments? You know what was surprising for me? Usually immunotherapy do not make such a profound myelosuppression, but I guess this is the group of, as you underlined, heavily pre-treated patients, and probably their bone marrow reserve is not that rich anymore.
Yeah, this could be a point.
Yeah.
It happens also in an allogenic setting that is not shown here. It could be a point, but maybe there's also something that is related to the product itself. But
and these patients also get the lymphodepletion therapy, and we know it, and Francesco is here, he can also comment. We also see this for ALL patients, these protracted cytopenias, which are not completely, the reason for this are not completely resolved.
Francesco, any comment? Nope.
I just have one question. I mean, the low incidence of peripheral neurotoxicity was surprising for me. If you look to the
dinutuximab,
I mean, I would have thought, oh, this is much, much more. Is there any explanation for that?
Oh, of course, they put all the prophylaxis measures. So, but really, I don't know. We still don't know if there's something different in the kinetic of the action between CAR-Ts and antibody-mediated toxicity. So it's probably due for surely a strict care of the patient, but it's not enough to explain this difference because it's very low grades and very low rates. So.
The CNS involvement, was this an exclusion criteria?
Yes, the CNS was an exclusion criteria, yes. I didn't put the full list of the inclusion exclusion, but yes.
Either you made it everything clear or they're very tired. Thank you.